Sure. So mantle cell lymphoma is peculiar amongst the lymphomas because it can present in different ways. Some patients have indolent disease that presents with just some abnormal blood cells in the peripheral blood that can be followed and observed over years. Some patients present more typically as a nodal lymphoma with an indolent presentation, a bit like follicular lymphoma with slow growth of the lymph nodes and spleen and sometimes B symptoms. Those patients can be watched for a while, but most of them will require treatment soon after being diagnosed. And then there's a small subset of patients who present with a particularly aggressive form of mantle cell lymphoma, which we now characterise according to mutations that we can identify with next generation sequencing. And so the approach for these different clinical presentations varies. And the other important factor, of course, is the fitness of the patient. So for a young transplant-eligible patient, our approach at MacCallum Cancer Centre in Royal Melbourne Hospital is to use a Ara-C-containing induction chemotherapy in combination with rituximab to take a patient to a deep response and then move to a consolidation autologous stem cell transplantation. We do actually do next-generation sequencing in all of our patients. And if we find the presence of P53 mutation, which we know predicts for chemorefractory disease, it's recently become our practice to use allogeneic stem cell transplantation as a preferred consolidation where a donor is available and a patient is young and fit enough to go through that, because we know that P53 mutation predicts for chemotherapy resistance. So we've recently adopted that approach, but that approach is not yet supported through randomised clinical trials. We do offer maintenance rituximab after autologous stem cell transplantation for these younger, fitter patients because there is a demonstrated survival advantage of that approach. In older patients, we may omit the autologous stem cell transplantation and we may choose a non-Ara-C containing induction regimen such as bendamustine and rituximab, which we typically give for 6 cycles. Whether we use maintenance or not is a discussion that we have with each patient on a case-by-case basis. Long-term maintenance antibody therapy was really evaluated in the pre-COVID-19 era, and so we find with older patients, and particularly patients with comorbidities, it's a highly individualised discussion about whether we're going to use maintenance antibody therapy after induction.